Thank you, Steve. I'm David Liska. I'm the chair of the Department of Colorectal Surgery here at the Cleveland Clinic, and it is my real pleasure to welcome everyone today to Live from Cleveland Clinic on Multidisciplinary Approach to Pelvic Pouch Dysfunction. And I would like to thank over 400 healthcare providers that have registered for today's event from across the globe, representing over 50 countries. So that's really awesome. And we want this event to be interactive. So please, during the program, interact via the chat box, and faculty members will answer any questions that you may have or will address them during the talk. I want to acknowledge our industry partners. So thank you for our corporate sponsors for the generosity, providing educational grants for the entire series for 2025. We obviously could not hold these CME offerings without our industry sponsors, and we're grateful to support from Cook, Janssen, and Medtronic. So again, thank you to our industry partners. And now, without much ado, I would like to introduce the faculty leaders for this event tonight, and that's Stefan Hollaba, one of my partners in the Department of Colorectal Surgery. He's part of our IBD section and the Director of Research for our department. And Dr. Kazi, who is a gastroenterologist and the Program Director for the Advanced IBD Fellowship Program in the Department of Gastroenterology, Hepatology, and Nutrition here at the Cleveland Clinic. Both Stefan and Sani besides taking amazing care of all of our pouch patients in a really multidisciplinary fashion, they're also leading active research programs on IBD and pouch dysfunction in particular. So I'm really excited to be part of this session tonight and hear from them and from the rest of the amazing faculty. So without much further introductions, please take it away.
Thank you again, Dr. Liska. I really do appreciate being here with a who's who of our pouch specialists and our faculty today. I'd like to introduce some of our panelists along with some of our speakers today. First off, it's going to be Dr. Olga Lavric. She's staff and department in the colorectal surgery. She's a fantastic inflammatory bowel disease surgeon and a clinical assistant professor in surgery at the Cleveland Clinic Learner College of Medicine. We also have Dr. Ariel Canters, also staff, who will be part of our panelists. One of my colleagues that I depend on all the time and related to IBD surgeries, and the director of the Colorectal Surgical Fellowship is to APD at the Cleveland Clinic. We have Dr. Manuel Braga-Neto, or Manny Braga-Neto. He's done some amazing and fantastic work regarding pouch and pouch inflammation. He's one of our assistant professors in medicine at the Cleveland Clinic and one of my gastroenterology colleagues. We also have Dr. Anna Spivak, our staff, Department of Colorectal Surgery, a leader in the pelvic floor space, and an assistant professor of surgery at the Cleveland Clinic. And last but not least, we have Dr. Ghassan Qasim. He's our advanced IBD fellow who will be presenting with us some of our cases. He's one of our star team members, and I'm looking forward to some of the case discussions as well as the conversation here today. Why don't we start off today with Dr. Olga Lavric. Olga, would you mind bringing up your slides and presenting on the surgical management in pouch patients?
Thank you very much, and good evening, everyone, and Happy New Year. And it's a true honor and pleasure to have an opportunity to present and speak tonight to be a part of this panel. And as we all know, a pelvic pouch, or more frequently called now a J-pouch procedure, has been pretty broadly adopted worldwide nowadays, and essentially has become the gold standard to restore intestinal continuity in patients who had required removal of colon and rectum, most frequently in patients with inflammatory bowel disease, specifically ulcerative colitis and determinate colitis, selected patients with Crohn's colitis, but also FIP and some patients with Lynch syndrome. And as we know, this is a life-changing procedure for patients, and complexity of it sometimes is compared even to a transplant procedure. Previously, our group has published results that up to 97% of patients who undergo J-pouch are happy with the surgery and have very high quality of life. But this was first introduced back in 1978 by, among only 5 patients, by Sir Parkes Nichols, who had proposed an S-pouch, preserving 8 centimeters of rectum and only stripping the rectal mucosa to pull the reservoir through the rectum and restores the continuity, and they reported 40% success rate. Afterwards, Japanese surgeon Dr. Utsunomiya has performed an international scholarship in order to make this procedure better and came up with a procedure called Procedure B, something what is a world famous J pouch procedure, where he came up with the idea of performing a J-shaped ileal pouch reservoir and suturing by hand down to the essentially very short rectal cuff. But what do surgeons really think when we are consulted on young patients with fulminant colitis who are failing medical management in the hospital and require urgent colectomy? Does it matter how the total abdominal colectomy goes for the future J pouch? It does, because everything really starts from a very thorough anorectal exam. And first, we have to make sure it's ulcerative colitis and not Crohn's. We have to rule out Crohn's disease, perianal disease, skin tags, sometimes do an examination under anesthesia. In the operating room, it comes to our mind how to manage the rectal stump. Do we do a 2-stage or a 3-stage procedure? If it's a 3-stage, do we simply staple the rectal off, or do we have to do a mucus fistula in case the tissue is just so unhealthy and so friable and we have to suture it to the abdominal wall? Does this impact future J pouch outcomes? Well, it certainly does, because it significantly increases the risk of pelvic sepsis in case there is a rectal stump blowout. But even on the long term, this can predispose patients to long-term infertility, specifically in young females. The rectum is so unhealthy, sometimes we need to do this. Sometimes we just need to wrap it and exteriorize. We just don't want to have pelvic sepsis, which will significantly delay the reconstruction. Here, I'd like to demonstrate when we do this completion proctectomy procedure and formation of the J pouch, how important it is the actual transection of the rectum very low in the pelvis, where we want the rectal cuff to be not more than 2 centimeters. This is a crucial step in success of pouch function, which significantly decreases the risk of pouch outlet dysfunction, down risk of cophitis, and pouch dysfunction in general. It has been shown that rectal cuffs longer than 2 centimeters are predisposed to difficulty in pouch emptying, strictures, and higher risk of cophitis. When we construct pelvic pouch, this is a classical description of the procedure performed at the Cleveland Clinic. In the past, we used ILA 100 staplers, usually 2 to 3 loads. Nowadays, it's GIA 100 staplers. But we want the pelvic pouch size to be in medium 15 to 20 centimeters. As we can see here, it's inflated with a septal. We want it to distend well to carry stool, and then the pouch empties by gravity. It works completely different than the rectum when the pelvic floor muscles relax and the pelvic pouch empties. Now, what if the patient has problem with emptying the pouch or increased bowel movement frequency? We go over to operative notes and we see what was the size of pelvic pouch, and we see what if it is 12 centimeters. What comes to our mind is really, okay, did surgeons have issues with tension? Did they have issues with length? Bringing this pouch down to the pelvis, and by creating the small pouch, they wanted to overcome those challenges. But in reality, this predisposes patients to having functional issues. And as we know, pelvic pouches can be various configurations. Historically, it has started with an S pouch, but even nowadays, sometimes it is used as it allows an additional 2 centimeter length to bring down the reservoir in the pelvis. J pouch is widely popular, but also W pouch and H pouch. And really, all of these are simply armamentarium in surgeons' hands to reconstruct the intestinal continuity. And here, what I'd like to show the Babcock ridge test. When before constructing the J pouch, simply bring the loop of the ileum down to the pelvis in the least tension-free manner, usually 4 fingers below the pubis, before we even start constructing the pouch. If that's a challenge, then several lengthening maneuvers can be done, such as high ileocolic vessel ligation, stripping of the peritoneum, relaxing peritoneal incision. This is a demonstration of stapled ileal pouch anastomosis, most broadly done today. And what's really important when the EEA stapler is fired, the nature of the rotation of the stapler can predispose to twist of the pouch, and down the road, this can be another lead point to decreased pouch emptying and difficulty with emptying and obstructive defecatory symptoms. And that's when we do pelvic pouch endoscopy and we see the All's eye, the afferent limb, and the tip of the J and the straight staple lines up and down rather than twisted 270 on 300 degrees staple line twist. Here I just would like to bring up that historically this started with the hands-on anastomosis, but even nowadays sometimes we have to do it if double stapled is not feasible. Something to keep in mind, hands-on anastomosis are more prone to having anastomotic strictures and sometimes require scheduled regular dilations when patients start having issues with emptying the pouches, increased stool frequency, nighttime seepage, or even incontinence. And does it matter what configuration of the pouch to do in setting of stapled anastomosis or enhancer? And study from here, done by several authors before, had shows that an S pouch configuration, as shown here, as it has a longer afferent limb, if it's longer than 2 centimeters, has better functional outcomes in configuration with a hands-on ileal pouch anal anastomosis rather than a stapled. And of course, after construction of the pouch, the ileostomy, and we call it a thoughtful ileostomy, preserving maximal lengths of the bowel upstream from the bowel, from the pouch itself, in case a patient would require a redo pouch in order to minimize waste of the small intestine. But what is the definition of pelvic pouch dysfunction? Well, this is the studies that I wanted to share on Delphi consensus, and this really is very broad definition. This includes soiling, urgency, frequency, clustering, nocturnal incontinence, and probably majority of our patients have this. But what do we do when they come with this? Well, first we have to go back to their initial steps, and we really need to see what was done. We need to listen to their symptoms. Did they really have septic complications, or did they have uneventual recovery? When did the symptoms have start? Right after the ostomy reversal or 10 years after? Is this Crohn's disease or not? And just to demonstrate, we'll talk about the cases later, but this is the patient after a robotic 2-stage proctoclectomy with a J pouch, and she came in with difficulty emptying her pouch. She had recurrent pouchitis. She was treated with 5 biologics without response to this, and she had filoportomies for ongoing recurrent bowel obstruction without transition point. We did an EUA, and she had a diagnosis of Crohn's with a pouch. She had this chronic ischemic changes in the pouch, irregularity of her pouch, and crossing staple lines on the 3D pouchogram. Well, she asked, yeah, are you sure I don't have Crohn's disease? And I feel we can never give them an assurance that this is not Crohn's disease. But the first step will be, again, to go back to their operative notes and to figure out what exactly they had done and rule out mechanical complications such as this one, which had 360 degrees twist of the ileal pouch and essentially complete pouch outlet obstruction. And this is a study also from Cleveland Clinic, Dr. Garrett, who had shown that up to 80% of patients with Crohn's disease of the pouch had a diagnosis of Crohn's disease while they had ongoing pelvic sepsis, what is demonstrated here on this illustration. And really, this is the first step to rule that out before going to biologics and different immune agents. Just to briefly classify mechanical complications based on the pouch anatomy can happen at the pouch inlet, afferent limb syndrome, pouch body itself, ileal pouch, anal anastomosis, and pelvic floor non-relaxation or paradox contraction. And a study from here as well, senior author Dr. Gorgon had demonstrated that up to 40% of patients with a J pouch developed recurrent small bowel obstruction in setting of paradox contraction of pelvic floor and had underwent unnecessary expiratory laparotomy for picture of bowel obstruction, but in reality had needed to have pelvic floor physical therapy or intubation, transanal intubation of the pouch. And just to summarize everything, the first attempt to create the J pouch is the best one and the best chance for the patient. What we're looking for is a tension-free anastomosis, straight mesentery. Do not leave the mesorectum behind, as it will really be an obstacle for the pouch to expand, accumulate the stool, and then to empty. And if the J pouch doesn't work, an S pouch can be an option. If it doesn't work, then we can come back another day. We can park the pouch in the pelvis. The goal is to minimize the pelvic sepsis, and most multidisciplinary approach in the pouch dysfunction here is key. Thank you very much for your attention.
Thank you, Dr. Laverick. That was really a fantastic overview of mechanical pouch complications in about 10 minutes, and thank you for staying on time tonight. We're so pleased to be able to highlight the multidisciplinary approach that you finished with your lecture with, because it's very much key to the whole problem that we're discussing tonight. And with that, we're going to carry on with the next didactic, which is by Dr. Manny Braganetto, who's also a member of the IBD section of the Department of Gastroenterology. And he's going to speak on medical management of inflammatory pouch disease, pouchitis and Crohn's-like disease of the pouch, update from the guidelines. Dr. Braga?
Thank you. I'm going to pull up my talk here and be ready to share. Right. Thank you so much for the kind introduction, Dr. Halabar. I'm Dr. Braganetto, like Dr. Halabar mentioned. I'm an assistant professor here at the Cleveland Clinic. My clinical interest is in IBD and pouchitis, and then my research interest is actually basic science mechanisms of pouchitis. And I'm really excited to give this talk, and thank you all for joining tonight. I don't have any disclosures in terms of objectives. We're going to go over the anatomy of the ileal pouch very briefly, since this was just explained ago, and also go over the pathogenesis of pouchitis, the diagnosis, assessment of inflammatory pouch disorders. And one of the highlights of the talk is going to be incorporating the first ever guidelines that was published last year in gastroenterology on inflammatory pouch disorders. In terms of background, so we all know that ulcerative colitis is a chronic condition and it affects millions of people in North America. Despite all of the advances in medical therapies, which currently include biologics and also small molecules, approximately 20% of patients still require colectomy for management of medically refractory disease. And as outlined, the total prostatectomy is really the surgical procedure of choice with the creation of the ileal pouch anal anastomosis. And this procedure overall in terms of the anatomy, just to review briefly again, this is outlined here, the J pouch, where you have an A, your efferent limb, the tip of the pouch. B, you have your owl's eye appearance, a normal healthy pouch during pouchoscopy examination. C, you have your pre-pouch ileum or efferent limb, and then you also have your cuff here outlined in D, typically about 2 centimeters, as was outlined. So with this in mind, patients oftentimes when they undergo, total prostatectomy, they really, wonder what's life gonna be after the creation of the pouch, and it's important for clinicians as well to know this, that overall the pouch function is pretty good. There's gradual improvement of the consistency of the stool, and the baseline number of bowel movements is going to change. It's going to be approximately 4 to 8. That's considered normal, and then they can occasionally also have nocturnal symptoms, but that's all within the kind of expected baseline. Fecal incontinence is something that can occur over the years. And important that I highlighted here, about 80% of patients will develop at least one episode of pouchitis. So that's important to know as a provider and also highlight that to the patients. And it's interesting because, we just talked about also other indications for colectomy and pouch creation. And FAP, for example, where the colon is removed and the pouch is creation for an indication of neoplasia. In that setting, only 10% of patients develop pouchitis. So also important to keep that in mind, and that highlights the complexity probably of the pouchitis related to UC. In terms of pouch complication, you just had an overview of the mechanical complications of the pouch, and I highlighted here some of the inflammatory complications, the highlight, of course, the focus of the talk. So we have our idiopathic pouchitis, which is going to be the most common, and you also have your secondary causes of pouchitis that primarily include infection, medication, radiation, and then cophitis, which is primarily recurrence of what we call the remaining colonic tissue in the we call cuff. So about 2 centimeters. And then you have your other functional and neoplastic complications as well, which we will also go over during the case discussions. In terms of the inflammatory complications of the pouch here, I highlighted the 3 most common ones that we're going to be talking about today. So pouchitis can be intermittent or chronic. And as you can see here, an A is a normal pouch, and C, you can see highlighted the inflammation, and that's a case of pouchitis, a classic pouchitis. And then you also have your Crohn's-like disease of the pouch. We'll go over the definition of that as well, but you can see that highlighted in G. There's some fistulizing perianal disease here. And then also the cophitis highlighted in F, which is inflammation of that remaining cuff. In terms of definition, so this is important as well. So pouchitis, inflammation of the mucosal pouch. Top right corner, you'll see the normal pouch without any inflammation in the owl's eye view, and then to the bottom there, you'll see the inflamed pouch. And the diagnosis is really a combination of clinical symptoms and endoscopic findings. In clinical practice, oftentimes the patients will sometimes even receive treatment with antibiotic therapy without undergoing a pouchoscopy. But I wanted to highlight that these symptoms, just kind of think about pouchitis, would be abdominal pain, diarrhea, rectal bleeding, and fever, and more complicated cases. Also highlighted here the scoring index, that this is important from the standpoint primarily of like research, but also thinking of the important things to think about when we think of pouchitis. So the PDAI score takes into account clinical symptoms, endoscopic findings, and then histologic findings. It's an 18 score system where 7 or greater is diagnostic for pouchitis. And then a lot of the clinical trials or the studies nowadays with pouchitis are incorporating this modified PDAI, which essentially eliminates the histologic scoring system, which can be somewhat not really standardized across institutions. So they essentially score of more than 5 or greater is diagnostic of a pouchitis. And then the pathogenesis of pouchitis, this is a really exciting kind of part of, to me, of the talk, and a lot of knowledge gaps here. And I'll spend a minute talking about this. To the left here, you can see the J pouch with stool, so fecal stasis. And on the left panel here, you have your normal pouch without any major inflammation. This is fascinating how the small bowel tissue is really forced to adapt over time to become somewhat of a colon-like tissue, primarily due to fecal stasis, change in the bacterial load that primarily becomes anaerobic, change in the metabolic composition. And it's important to note that the tightness of the barrier of the pouch is going to be important, probably for the for the issue of pouchitis. As we highlighted, UC patients 80%, FAP patients only 10%. So on to the right here, you have a patient with pouchitis, and it really primarily dysbiosis is really important, as we know, response to antibiotics. But ultimately, that dysbiosis leads to metabolic changes, a break in the barrier function, translocation of the bacteria, activation of the immune system. And so really a complex condition that a lot of mechanisms to be determined. Risk factors for pouchitis include extensive UC prior to IPAA, backwash, ileitis, primary sclerosing cholangitis, NSAID use, and concomitant immune-mediated inflammatory disorders. Now, the highlight of the talk, we wanted to go over this brand new, first ever guidelines that came out last year, and some important, questions, of course, that the authors asked are highlighted here. One of them was primary prevention and secondary prevention, the role for antibiotics and probiotics, and then the other one was treatment of pouchitis and Crohn's-like diseases of the pouch, as well as cophitis, taking into account the available literature, effectiveness of antibiotics for pouchitis, probiotics, and then also advanced therapies. One important thing to highlight is, although we mentioned the pathophysiology of pouchitis is complex, currently we don't have as a goal of treatment to achieve mucosal healing as we do in broadly speaking IBD. Really, the target is resolution of symptoms. And another important update here that I wanted to highlight before we even start was one is trying to standardize the definition primarily of chronic pouchitis, and then we'll also go over an important trial, first ever also, the New England Journal of Medicine, that looked at vedolizumab and pouchitis. Some of these pragmatic definitions: so intermittent pouchitis, isolated and frequent episodes. Chronic pouchitis can be divided in antibiotic dependent and refractory to antibiotics. I highlighted this as an update from the guidelines because previously there was a number, so 4 or more episodes a year of pouchitis over 12 months that would then be diagnostic, and they actually now went away with the number of episodes. And with antibiotic dependent pouchitis, they're saying that there are episodes of pouchitis that respond to antibiotics but then will recur over time. And then in terms of Crohn's-like disease of the pouch, really important to highlight, within 12 months of surgery, you want to think about surgical complications, but if you're having fistulas after 12 months, perianal disease, strictures of the pre-pouch or the pouch body, and pre-pouch ileitis, that's when you start thinking of Crohn's disease like of the pouch. In terms of the first question of, the guidelines prevention. So Really, primary prevention, I didn't even go over too much detail because really there's no recommendation in favor of them. But I wanted to highlight for secondary prevention in patients that had recurrent pouchitis, and primarily patients that actually had chronic pouchitis. Data from 3 randomized controlled trials that used the Simone formulation, which is a more standardized formulation of probiotics, notice about 87% lower risk of relapse within 12 months. And this led to then the panel and the guidelines to say that they're in favor of probiotics for that indication. For intermittent pouchitis, the highlighted here, the guidelines are in favor of antibiotics. There's more extensive data. This is a meta-analysis that highlights 4 randomized controlled trials and then 8 observational studies that demonstrate a response rate of about 65%. In terms of the management with antibiotic therapy, we typically think of ciprofloxacin or metronidazole. Most of those studies included those 2. Other alternatives include vancomycin and rifaximin in patients that are not responding or have allergies to those other antibiotics. And the duration is typically 2 to 4 weeks. In terms of the guideline recommendation for probiotics in terms of treatment, they didn't have any recommendations against or in favor. And this is for a mix of reasons, but one, again, kind of a heterogeneity in terms of the formulation here of the probiotics, the cost, insurance, and unclear really if there is much of a benefit. And that could ultimately also delay treatment with antibiotics. Then in terms of the guidelines for chronic pouchitis, antibiotics, we know that this is an indication for both acute but also chronic pouchitis. The authors are in favor of this, but then highlight the importance of cycling antibiotics and perhaps also having like a week break in between. And overall, in terms of safety, the data that we have suggests pretty low adverse event. Like I mentioned, the New England Journal trial that came out last year, it was the first trial on management of chronic pouchitis, and it was a multi-center trial involving 102 patients that had essentially chronic pouchitis, and they treated these patients with vedolizumab. The primary endpoint was was remission from the MPDAI standpoint at week 14 and then 34, and then secondary endpoints were also assessed here as an essentially response to therapy based on the MD-PAI. And as you can see here, there was a significant difference at week 14 and 34 with remission. Approximately 30% patients here, as you can see, 35% patients had remission at week 14 and 34, and response was up to like 63 or 51. I wanted to highlight just a quick caveat with this study is that antibiotic use was permitted during the trial, and that could have confounded perhaps the results, but exciting that we now have data on this. In tofacitinib, there's an open label study that demonstrated efficacy as well. So in terms of management of Crohn's-like disease of the pouch, big picture thinking of this is that you manage it primarily as you would manage a patient with Crohn's disease, typically with advanced medical therapy. There's here is a summary of the available studies, 10 cohorts, no RCTs available, but primarily showing a response rate of 74% when you use biologic therapy or immunomodulators. And important to notice that a subset of patients may continue to benefit from some antibiotic therapy, and that recycling therapies with prior biologics that had been used is also something to be considered. And finally here with the management of cophitis, just to say that there's limited data. The guidelines are in favor of managing this as recurrence of ulcerative colitis, primarily with topical therapy first, mesalamine and steroids, and in patients that have refractory disease, then using biologics or more advanced therapies is also recommended. So to summarize here, the guidelines, prevention of pouchitis highlighted here in orange, no recommendation in favor or against the use of probiotics for primary prevention, against antibiotics for the management of primary prevention, and then in favor of probiotics. This is a big take-home point that this can be used primarily the Simone VSL3 formulation for patients that have recurrent pouchitis. And then treatment of pouchitis, essentially, as we discussed, antibiotics continue to be the mainstay for both acute intermittent pouchitis and also chronic antibiotic therapy. The guidelines also recommend considering, of course, advanced therapy in patients with Crohn's-like disease of the pouch. And one important thing to highlight too, they recommended against use of 5-ASA therapy for management of pouchitis. And as I mentioned, cophitis you manage as recurrence of ulcerative colitis. So all this, to essentially highlight the importance of having this algorithmic approach to management of chronic inflammatory pouch conditions, thinking of making sure that you're excluding alternative etiologies in a patient that's not responding to your standard antibiotic therapy, and then further subdividing patients that have Crohn's disease like of the pouch after undergoing further testing, or refractory versus dependent antibiotic therapy. And this ultimately will lead to an algorithmic approach where you're able to then diagnose patients with Crohn's-like disease of the pouch and treat adequately with advanced therapy. And then patients that have chronic pouchitis be able to determine if they need advanced therapy or not. And to summarize here, take-home points then, obviously this talk also highlights that pouchitis should be managed as a multidisciplinary condition. Most patients have a pretty good quality of life after creation of the pouch. Complications can occur, approximately 20% of patients. And then having this rationale kind of algorithmic approach will help optimize your therapy. And the recent guidelines that we reviewed here compile these definitions and also limits variation in practice. With that, thank you.
Thank you again, Dr. Braganeto. That was a wonderful talk and a comprehensive understanding of how we medically manage pouch and inflammatory complications of the pouch. I'm going to turn it over to Dr. Anna Spivak, one of my colleagues and someone who I speak with regularly on how to manage pelvic floor disorders in pouch patients. And Dr. Spivak, why don't I turn it over to you to review the pelvic considerations associated with pouch creation.
Hi, everybody. I'm Anna Spivak. I'm a section chief for pelvic floor surgery here at the Cleveland Clinic, and we will completely change gears and talk about problematic pouch and functional issues of the pouch. So I'm going to touch base on a couple of topics today. Dyssynergic defecation, which Dr. Laverick alluded as to why that happens. I'm going to talk a little bit about pouch prolapse and fecal incontinence with the pouch. So starting with obstructive defecation. So obstructive defecation in a patient without a pouch and with a pouch is similar, but has different causes a little bit. So it's essentially in a normal defecatory process, the puborectalis muscle needs to relax and muscles open up, relax, and the defecation process happens in a patient with a rectum with rectal contractions. And in a patient with a pouch, it's slightly different because there's no rectum. But still, puborectalis needs to relax. And in cases where it doesn't relax, it can even contract further, causing the paradoxical contraction and obstructive defecation process. This creates pain, bleeding, and sensation of incomplete emptying. Patients are not able to evacuate because essentially they're pushing against the closed doors. The anus is closed, they're pushing against contracted muscles. It can cause prolapse and overall pouch dysfunction. So obstructive defecation can be divided into two categories. The primary with functional dysesthesia or painful defecation without inflammatory or structural conditions. So this is just purely a failure of muscles to relax. And a secondary with the patients with inflammatory or structural conditions. So those are the patients who may have cophitis, they may have a stricture, they may already have a prolapse. So there's something else that causes the painful defecatory process. Some of these patients usually it's a clinical diagnosis, and a lot of the times based even on the patient's description of symptoms, you can gauge that they do have obstructive defecation going on. But many of these patients will get manometry. And on manometry, we will see oftentimes asymmetric sphincter contractions. We can see poor pouch sensation. We can even see sawtooth pattern contractions, which would indicate spastic contraction of the sphincter. And what causes this, right? So some of these patients would come into before even getting their pouch while they had their ulcerative colitis, and maybe they had frequent bowel movements, and they already developed some degree of pelvic floor dysfunction. Not everybody, some patients will have that, but for others, what causes that pouch anal dyssynergia? And that is essentially a functional problem. So patients need to be educated on how to poop with a pouch. And the natural inclination is to bear down. A lot of them will bear down very quickly to expel stool. They some of them would push hard and fast and sit in the toilet for a long time. So over time, essentially giving themselves pouch anal dyssynergia. And the solution for that is essentially patient education, which starts before surgery. And before surgery, it's very important to educate them on what their defecatory function will be with a pouch, because they may have the best pouch, but if they're not using it properly, they will end up with a problematic pouch. So setting reasonable expectations, telling the patient that having multiple bowel movements a day is normal. They may have up to 12 bowel movements a day, and for them it might be normal, which we'll talk about it in a second, but just letting them know that it's not going to be just several as they had before. Letting the patient know that pouches can be noisy. Because that can be an embarrassment factor, and the patients may want to finish their defecation process really quickly, especially if they're in a public place or at work. Going slow and steady is the most important thing, and I will mention it several times because that's essentially what they need to do. So they need to relax, open up the muscles. They do require some abdominal pushing, but not so much straining of the pelvic floor to defecate, because as Dr. Laverick already said, pouch empties by gravity. So completely different process from normal defecation. So relaxation of the muscle, gravity emptying with slight abdominal, increase in the abdominal pressure. That's what will allow them to empty their pouch properly. It can take 3 months for bowel movements to find a new normal. So patients have to be very patient with their defecation in the beginning. And the first bowel movements will be very, very frequent. So remembering that immediately after, they need to have skin protection, maybe even long-term skin protection to make sure that they don't add irritated skin in addition to everything else. Going slow and easy, as I said. And if there's no bowel movement, do not sit in the toilet for a long time. As the diet gets advanced, roughage is introduced that can get the bowel movements to be more formed. However, they will always be semi-liquid consistency, and that's important for the patients to know because they would not be able to evacuate formed stool, and that will cause also pouch problems. In the follow-up at several months when the patient's already at the regular diet and they're still having 8 to 12 bowel movements a day, Imodium can be introduced, and it's very important to educate the patients how to take it. So the box says take it for 7 days. It's important to let the patients know that it is safe to take it long-term. We usually start with Imodium twice a day, and if they can tolerate it and they do have reduction in bowel movements, they can go to 3 times a day, and then further taking the Imodium specifically 30 minutes before they eat, and then once again at night to achieve that desired consistency of still soft and mushy bowel movement, and but decrease in the number. After the patient gets their pouch, it's important to continue that education. So the patient in their follow-up says that there's straining. So it's important to evaluate, do the digital rectal exam as well as flexible sigmoidoscopy. And essentially what we're looking for is we're making sure there's no pouch, there's no IPA stenosis, so there's no narrowing. And on digital exam that they do not have paradoxical contractions. Also ask the patient how many bowel movements they have, the stool consistency, because here you will talk about changing the diet patterns. Pouch patients cannot just get away with drinking coffee in the morning. They need to be eating breakfast so that they can bulk their stool from the early in the day. Does their work schedule allow them to have enough time to defecate properly without having to force that stool out and needing to, do it very, again, fast and hard pushing. And then again, if the pouch endoscopy is done and there is pouch inflammation, there could be consideration for a short course of flagell early on in the recovery period. So if they do have a dyssynergic contraction of pubic talus, in addition to education, everything that I just talked about, the patients will be referred to biofeedback. And dyssynergic contractions are reversible. They just need to learn proper techniques on relaxing the muscles, and we'll be working with physical therapists to achieve that. And the resolution of the dyssynergic contraction can also improve their overall mild chronic inflammation of the pouch or the cuff. And we'll talk a little bit about that more. So then the patient comes in and they've had a pouch for a long time. and the pouches, they're having difficulty evacuation. At that point, we will consider doing a defecatory studies, so defecography as well as getting a pouchoscopy. Again, we're looking, ruling out anatomical problems, but also looking at the size of the pouch. And if the patient have not been emptying for a long time, their pouch will be dilated and it will get big. So at that point, consideration for intubation of the pouch. And the idea here is to drain the pouch, and this is done every 4 hours. At least in the beginning, to drain the stool out of the pouch, to allow for the pouch to decompress, and then retrain the muscles again with biofeedback and physical therapy to get better, improved function. Some patients who are not able to accomplish improvement in their muscle relaxation do need to intubate pretty much for the life of the pouch. So it's the only way they can empty. And the stool needs to be, obviously, it's a catheter that goes into the anus. Patients are usually not very excited about doing that. They need to have extensive education on the techniques of it and to get them comfortable to do that. But also stool needs to be more liquid for that. So this would not be the patient to use Imodium in, and maybe sometimes even Miralax is needed. So Dr. Laverick already put up the study. So this is a similar CT scan from a patient who had dyssynergic defecation and had very big dilated pouch, presented to the emergency room with essentially obstructive symptoms without a clear transition point. At this point, it's usually too late to teach them how to intubate. This actually was a patient who refused to have intubation and has had this problem for a long time. So in these cases, there would be no transition point. The patients usually get a diverting loop ileostomy to allow for the pouch to decompress and everything to settle. And after that, just evaluate what needs to happen further down the road. So this is the same study that Dr. Laverick put up. So it's just remembering that not every small bowel obstruction patient with pouch is an actual bowel obstruction, but it can be secondary to the obstructive defecation process. This is another study, and this is showing that non-relaxation of pelvic floor dysfunction can be a complication of the ileoanal pouch anastomosis. And here they looked at the chronic pouchitis and showed that there is a higher correlation between the patients with chronic pouchitis and patients who had a non-relaxation of their sphincter complex, so essentially obstructive defecation. So for the patients, it was a significantly higher portion of patients with chronic pouchitis with non-relaxation, with 83 versus 63, I'm sorry, 62%, 83 versus 62. And the conclusion from that paper was that biofeedback seemed to be an effective therapy for patients with IPAA who are non-relaxers, and further studies are needed for validation. So moving away a little bit from obstructive defecation to the next topic, and this can be a sequel of obstructive defecation. This is the pouch prolapse. So very rare problem, 0.3% incidence in the pouch patients, but it can be quite devastating when the pouch is prolapsing. And the pouch prolapse can be full thickness or mucosal. And essentially, it's an external protrusion of the pouch through the sphincter complex. But it could also be very little protrusion, not like the picture that is here, but patients will have pain with defecation and they're having a difficult time emptying. They need to strain. They can also have seepage, and they can have a sensation of not being completely able to empty completely, so sense of obstructive defecation. So in this patients, if endoscopy were to be done, it can show erosion, ulcerations, so chronic inflammation. It can also show floppy pouch. And the biopsy will show can show some inflammatory changes again, and integrate smooth muscle fiber disruption and thickened muscularis, again, consistent with constant pouch movement in and out. This is a defecography demonstrating a type of pouch prolapse, so they can be very different. So they can be an anterior distal pouch prolapse, and distal pouch prolapse is usually a sequel of incompletely suspended pouch or sort of a floppier pouch, which will prolapse out of the anus. There could be anterior cuff prolapse. There could be prolapse of the pouch dome, which is in the pouch inlet, which is similar to intussusception process. So that starts sort of internally, can give them sensation of incomplete emptying. There also can be a pouchocele or enterocoele. So not this picture is a pouchocele. So this is not dissimilar to sort of outpouching of the pouch into other spaces. An etiology of the pouch prolapse is essentially dysynergic defecation, what we talked about. It is high in patients with connective tissue disorders. We have looked at our cohort, and unfortunately the numbers are very small to make any conclusions, but it is a slightly higher incidence at pouch prolapse in patients with connective tissue disorders. And most importantly, straining. So these are the patients who are habitually straining and eventually end up with a pouch prolapse. So what do we do about it? So the most important thing is to fix the underlying cause, is because if the patient's pouch prolapse is because they're straining, if they can be best paxi of the pouch and they will recur at just a matter of time. So if you're thinking about fixing the prolapse, the first step would be to identify the cause, whether it's dysynergic defecation or habitual straining. But without dysynergia, the patients do need to undergo pelvic floor physical therapy, retraining in order to have better defecating habits. Then prolapse can be mucosal, and sometimes it can just be managed conservatively if they're not straining as much. They do not prolapse the mucosa, so sometimes it's managed conservatively. And then other times it would be appropriate to do a perineal procedure, essentially with a pouch advancement and excision of the redundant mucosal tissue, which is what is demonstrated here in the picture. If the prolapse is full thickness, the various techniques that have been done, and most of them are variation of pouch paxi, essentially doing an abdominal procedure and paxing the pouch. The mesentery of the pouch is paxied to the sacral promontory as well as presacral fascia. And there is also a biologic mesh technique that has been used as well. So this is a paper from Cleveland Clinic. So they looked at the 4791 patients, so close to 5,000 patients, and 7 patients had a prolapse, so 0.1%. Interestingly enough, only 64% women, and it takes 4.2 years to develop pouch prolapse, not rectal, after the creation of the pouch. 80% of the patients underwent pouch paxi, 20% had a mesh repair, and 12% recurred at 6.9 months. So the conclusion from this paper was that pouch prolapse can be effectively treated with salvage surgery, and surgical intervention is safe and provides acceptable outcomes. This is another older paper, also from the Cleveland Clinic, and they looked at the pouch prolapse as well. So the incidence was slightly higher, 0.3%, but the cohort was also smaller. So 7 full thickness prolapses and 4 mucosal. They had a shorter interval to the prolapse, 2 years. 2 of the mucosal prolapses were managed conservatively. And the 7 patients underwent the paxi. I guess the remaining 2 just didn't have any surgery. But of the patients who underwent paxi, 3 recurred. So they had a pretty high recurrence rate, so 40-some%. And all of those patients underwent a continent ileostomy as a salvage procedure. And then this is another paper, and this is actually a case report on the usage of the mesh as a salvage rectopexy, and they put the mesh on the mesentery and then fixed it to the sacral promontory. And you can see in this picture the synthetic mesh right there that is demonstrated. And it's a single case report. There's really no studies on using the mesh on the pouch. Anecdotally, we do have some patients who have pouch paxis with a mesh and do incredibly well, but it's a very has to be very correctly selected patient and certainly a well-performed technique. So moving on into fecal incontinence. So was touched by 2 previous speakers. So not uncommon. So this is a summary of 2 papers. So as you can see, time of surgery, and we see the increase in somewhat of an increase from 2 years to and on in the sometimes incidence of fecal incontinence. But again, for most patients, looking at their quality of life, they still were content with their function of the pouch, even with incontinence. So this is looking at another paper, the same two papers, so looking at the 10-year outcome from surgery. So 80% had no incontinence, 30% some seepage, and 20-some% were a pad. This is so not an uncommon problem, but very variable reports in different papers. So this is another paper from the Cleveland Clinic. However, here you can see that seepage was significantly higher, 56%. And then they looked at the specific subset of patients. They look at the 70-year-olds, but looking at a high seepage rate, high incidence of pad usage, and some incontinence was seen in 42%. So certainly may correlate to the age. But as you see, the quality of life and level of energy and level of happiness with outcome of surgery was very high in all of these patients. So not an uncommon problem, but how do we address that? So the first thing when you see the fecal incontinence that is new in the patient with a pouch is to rule out anatomical and functional problems, just as we talked about consistency of the stool, strictures, pouchitis, all of the things that have been discussed before, and then discuss with the patient what else has changed. Is the patient who has some paradoxical contractions and they need to be intubating the pouch, doing an enema before they're going to bed, and certainly using some skin protection. There's very little data on using a sacral nerve stimulator in the pouch patient. There is just one paper that's been published on that, and they looked at 12 patients. Total, 83 of those 12, in the study of the 12 patients, 83 of those 12 patients underwent sacral nerve implantation for the pouch associated incontinence. They followed the patients for 24 months, and they don't quantify exact improvement percentage, just saying that the symptoms improvement has been demonstrated in this cohort of patients. So something that certainly can be considered for pouch incontinence. And the take-home points that patients need to be educated and re-educated about pouch function. Very important to remember to teach them to go slow and steady, fix the underlying cause before attempting to fix the problem.
I'll have the panelists all come up, and as Dr. Kasim brings up his presentation, I'll ask some of the questions that have been coming up. Dr. Spivak, thank you again for that excellent presentation. Mandy, one of the questions that sort of came up in the chat was this idea that when you, and I think this is something that we've also seen, when you bring 3 gastroenterologists to a room and you ask them what Crohn's-like disease of the pouch is, you get 6 different opinions. It's like that old joke. So how do you, and how does the guidelines define Crohn's-like disease of the pouch?
Yeah. So typically for me, Crohn's disease of the pouch, I think it's important like to start out with like the timeline of things when you're thinking that you're starting to have the typical findings of like strictures or fistulas. If it's within 6 months or a year after the surgery, it is on the differential, but you want to think about possible surgical complications. The location of where you have the strictures also helps. For example, if you have stricture of the pouch body, or perhaps even stricture higher up in the pre-pouch ileum, that would be more suggestive of the Crohn's-like disease of the pouch. And if you have perianal disease as well. So the definition really typically for at least for the guidelines, they mention, you know, having perianal disease with fistulas that are associated with strictures, and if they are, the pouch body typically, and then also in terms of response to antibiotic therapy as well as something you want to think about as well if they've failed in the past. But typically fistulas, and we're thinking of more than 6 to 12 months after surgery.
The idea of strictures as well, and then obviously pre-pouch inflammation.
Right.
One of the other questions that came up, Dr. Laverick, is the idea is, and this is maybe controversial, the question of how is there a role for a single stage pouch creation in the current practice of pouch surgeries in at all? Or is this sort of a controversial aspect? I know that we can do 3-stage pouch procedures, but have you or any of your colleagues attempted or done a single stage pouch creation?
Yeah, thank you. I think a single stage is now more historical perspective. I don't think I don't think anyone does it anymore. I know we had some papers on the single stage J pouches in the past. Normally, in the past when it was done, of course, it was a single stage procedure. But from knowing our patients, and we have more than 5,000 now, in the past when they admitted that divergent ileostomy, those would be patients with morbid obesity, if they can't burn up a divergent ileostomy, accepting the risk of pelvic sepsis. But nowadays, I believe like that is gone. It's 2 stages more done in patients with quiescent IBD or FAP who have not been on biologics and can have total proctocolectomy and DLI rather than a 3-stage for who essentially had failed medical treatment.
I see that Dr. Katie Falloon just showed up. Thank you again for showing up, Dr. Falloon. Dr. Karras, one other question came up was the idea behind mesenteric lengthening procedures. Dr. Laverick mentioned the mesenteric lengthening procedures. What is your sort of algorithm when you're having a hard time getting the pouch to come down or having a hard time parking that small bowel in the pelvis?
After crying, so the primary things, first off, just making sure you have a true high ligation of your ileocolic artery, because that can be one of your most tethering aspects in your pouch descent. So really truly taking it at the root, coming off the SMA. Also, fully mobilizing the root of the mesentery off of the duodenum. So taking it, or duodenum. So making sure that it's fully, the root again is no longer tethered to the pancreas or the D2, D3 region. In terms of, so those two don't risk your flow to the pouch in the same way that other like scoring measures will. One important lesson that we're all taught here who train at the clinic is you don't cut the cuff until after you've checked your measurement lengths. So the fact is, as much as we say our goal of a 1 to 2 centimeter rectal cuff is absolutely the gold standard for what we're doing, because we don't want to risk our cuffitis, our persistent inflammatory change concerning for risking dysplasia, etc. But if ultimately, despite all lengthening maneuvers, your difference is about 1 centimeter and you have an opportunity to potentially leave a slightly longer rectal cuff, that may be a necessary maneuver. On top of that, transitioning from an MIS to an open approach, if you cannot appropriately get what you need through a laparoscopic or robotic approach, an open incision will give you more flexibility. You also have a lot better opportunity to ensure that your reach is really going all the way down to the pelvis. So even utilizing a fan and steel incision, that won't help much in terms of getting up to the root of the mesentery, but doing a fan and steel to really know that you're sitting yourself down in the pelvis. A couple other maneuvers that we will use, especially in the setting of something like a hand sewn, is even parachuting the pouch into the pelvis. So actually placing stitches that don't bring the pouch down to the dentate line or your planned IPAA, but actually then throwing your stitches with that gap and slowly kind of bringing them down in a staged manner so that you can offload your tension. So all of these maneuvers do certainly kind of raise our sphincter tone, because we could become increasingly concerned about the unnecessary tension that will be placed on this pouch. But a combination of those, at least according to the pouch gods that we all have learned from, majority of the time you can do it. And I have had one circumstance where even Dr. Hall had assisted me, and we truly did. We parked the pouch in the pelvis, meaning that we tacked it down to the presacral fascia, leaving about a 2 to 3 centimeter gap. And this was in the setting of a redo IPAA, and he's currently 7 months into waiting. We got 5 more months, and we're going to go and attempt our anastomosis.
That's wonderful. That's a truly a master class. Some of the questions that have come up before we start the presentation, before I parachute myself onto my colleague to start the cases. Dr. Falloon, how do you treat cuffitis with concomitant pouchitis?
So sometimes it can be really helpful to start a topical therapy for the cuff, because that can make the patients really symptomatic. So I'll do like a canasta suppository, something like that, for example. But if it's truly bad inflammation in the pouch, I'll also be thinking about starting an advanced therapy at the same time to get things under better control.
Wonderful. Dr. Kassim, why don't you bring up your presentations? A lot of our questions will be answered as a consequence or in context of the presentations, and I hope to continue to stimulate discussions. Dr. Kassim, I think you may be muted, but you can go and start.
Yep. Thank you so much, Dr. Kazi. Thank you, everyone, for letting me be part of this amazing panel. So I have two quick cases for us. We have three, but we'll go through two very quickly. Let me just scroll. Okay, so this is a case of a 32-year-old male who had history of ulcerative colitis. He was diagnosed at age 22. He was on multiple therapies before he eventually needed surgery. So at age 29, he required to have a 3-stage pouch creation. And then within 6 months after his surgery, he was doing perfect. He was having 6 bowel movements a day, 1 bowel movement at night, and he was having no complaints. Now he comes about 3 years later, after his pouch creation, complaining of an acute onset of pouchitis symptoms, if you will. He was having more than 10 bowel movements a day, more nocturnal stooling. He was having incontinence episodes, abdominal cramping, and he started to need to use more antidiarrheals. Initial workup showed elevated fecal calprotectin, elevated C-reactive protein, but the infectious workup was negative. This is a representative image from his images from his pouchoscopy. You can appreciate that there is very significant inflammation throughout the entire body of the pouch, ulcers affecting almost the entire surface area. There was no inflammation in the pre-pouch ileum or in the cuff itself. And then the biopsies didn't show any infections with CMV, but confirmed what we found, severe chronic active enteritis with ulceration. Patient was started on a 2-week course of Cipro, and then he was also put afterwards on a course of Flagyl. And by 4 weeks, the patient was reporting minimal improvement in symptoms, and he still was pretty symptomatic. Patient was very frustrated. He was under the impression that his disease was cured, was very disappointed to be going through those symptoms. So this brings us to our discussion points.
So thank you, Dr. Kassem. So why don't we start off with a sort of general discussion point. Dr. Spivak, how do you approach someone who's having a pouch? Do you refer to a pouch or a pouch creation as a cure for their disease, or how do you sort of voice it? Sometimes this, as we've seen, a lot of these inflammatory complications can occur through our conversations with Dr. Braganetto and whatnot. So how do you approach these conversations as they're sort of these patients are coming to you for this discussion?
So the most important thing is to listen to them, right? What's their problem? Are they, does it seem to be a functional problem? Do everything that I talked about in my presentation, are they having issues emptying? Are they having, how their bowel movements, how often they have them? Do they have any seepage? What is essentially happening to their pouch? So they will give you 50% or maybe even 70% of the information in just the story, and then some prompted question will give another 10. And then, at that point, move on to any kind of testing. If I'm suspecting that the patient is not emptying properly, may consider getting defecography, and at the same time, usually get a pouchogram. We at the same time, definitely doing a pouchoscopy and starting out with trying to first rule out any anatomical problem if that's suspected, and then after that moving on to functional problems, and obviously is the pouchitis primary or secondary problem there, right? As we often talk about that.
Exactly. So that's a great point, highlighting the workup as well as some of the management conversations. This is often a multidisciplinary pathway for when we do the work here. Oftentimes I'm in the OR with both you or Dr. Cantors, and we have a full pouch center and team here. And it really, I benefit so significantly from being in these sort of conversations. But in this situation, Dr. Braganetto, what would you say is your sort of leading diagnosis, and how would you counsel the patient in this diagnosis? As a patient who's been on antibiotics now, let's just say we've done some of this workup at this point. What are your thoughts?
Yeah, so I think that conversation initially too about the cure, mentioning that about 20% of patients will ultimately develop chronic pouchitis, and 10% can even be diagnosed with Crohn's-like disease of the pouch. At this point, with the lack of really response to antibiotic therapy, I would say that this falls under the chronic inflammatory pouch disorder. That's kind of how I would label it. The ulcerations there look pretty deep, so I think Crohn's-like disease of the pouch is high in the differential, but possibly chronic pouchitis refractory to antibiotics is also a possibility. The kind of common ground there would be advanced medical therapies, and In patients that have somewhat of a response to antibiotics, you can consider like combination antibiotics for 4 weeks, but I think this patient hasn't had much of a response. So I think the discussion then in terms of counseling would be you were likely going to have to be in an advanced, therapy, biologic therapy, obviously he's had in the past, versus potentially small molecules, and going over kind of risks and benefits of that as well. So that's usually how I start the conversation. I think further testing as well would be, important in this situation, cross-sectional imaging to make sure there isn't evidence of like Crohn's disease higher up in the small bowel, cross-sectional imaging of the pelvis as well to rule out fistulas. And that to me will change a little bit how I would choose the biologic therapy in this case as well.
Thank you again, Dr. Dr. Falloon, when you're looking at this patient and you're seeing this patient, how do you sort of incorporate, we talked about different therapies. Let's just say this patient does have chronic antibiotic refractory or pouchitis or something of that sort. Do you tend to recycle a therapy that they've been on in the past? So, for example, if they were on infliximab prior to their colectomy, or do you give them a chance at a new therapy, or do you tend to use whatever is at hand in the absence of a fistula, obviously?
Yeah, so for this patient, I believe he'd already been on 2 different anti-TNFs, one of which he developed antibodies to, so that may not be my first choice for him in particular, just for that reason. But it is not unreasonable to recycle medications if they've been on it previously without issues or side effects. I often start in these patients, there's some nice data for vedolizumab, which also has a very favorable safety profile. So that might be a nice choice for him. But I think in general, sort of the medication that the patient is able to get and that they're comfortable with, I'd be willing to start.
That's great. Why don't we move forward and discuss the second case so we can keep the conversation going.
Thank you. Okay, so here's our second case. So this is a slightly different case. This is a 50-year-old male. He also had medically refractory ulcerative colitis. He was diagnosed at age 20. At that point, he was treated with topical mesalamines and oral mesalamines for a few years. But then by age 28, he has become medically refractory and he underwent a 3-stage pouch creation. Post-op, he did great. He was having 6 bowel movements a day. He was having no other complaints. And eventually, he was just lost to follow-up. And then he presented at age 50, and he was complaining of the following symptoms. He was complaining of abdominal fullness and distension. He was getting full very quickly. He was nauseous. He was having a lot of abdominal cramping. Most importantly, he felt he was no longer able to fully empty his pouch. And he was having very small but very frequent and uncomfortable bowel movements daily. He said that this has become noticeable to him over the past 3 months, and it has been getting worse and worse over time. So here are our discussion points.
So this is a great conversation. Why don't we move forward? Because I think we want to sort of, I think we'll have a larger discussion point after the testing that we have.
Thank you. So here is just some of his workup. So this is a CT enterography image, a sample image, just to show how distended the small bowel is above the pouch. You can also notice that the pouch is pretty full with content, and they commented on a relative narrowing of the essentially the pre-pouch ileum at the point where it enters the pouch. So that was the CT enterography. Here is a representative images from his pouchoscopy. You can notice the body of the pouch it's underwhelming. There's minimal inflammation, but it's certainly not severe. And then this is a picture of the pre-pouch ileum, and you can appreciate how distended and dilated it is, but the mucosa itself is underwhelming. It looks pretty healthy. The cuff appeared normal. There was no evidence of an anal stricture. And then biopsies were taken from the pre-pouch ileum, the pouch body, and the cuff, and they were all negative for inflammation. And then I'll share here the findings from his anorectal manometry study. And they noticed that his resting pelvic muscle pressures were elevated. And then when he was asked to squeeze, his pressure rose, but it was above average. He was unable to expel the balloon. And then when they had him essentially do a Valsalva maneuver, he had paradoxical increase in the activity of the pelvic floor.
So, Dr. Spivak, you see this patient who has an ostensibly clear-looking pouch, uninflamed at all junctures. What would you think is the best diagnosis? And you kind of mentioned this in a lot of your presentation. How would you counsel this patient, and what are the next steps in management for this patient?
Sorry, I'm muted.
Yeah.
Again, we have a great history, we have imaging, so doing a physical exam and seeing, assessing the pelvic floor, assessing the muscles, assessing the contractions of the pouch, of the muscles, and is the patient relaxing in Valsalva, and really counseling, trying to gauge what the defecatory habits of this patient is. And, there was a question in the chat about is it necessary to do the defecating proctogram or any other imaging? Sometimes not, right? But definitely starting with pelvic floor physical therapy and just changing the habits of the patient. It's a pretty dilated pouch, so maybe in this particular patient, there may be consideration of intubation as well. And teaching the patient to do that, but definitely together with pelvic floor physical therapy.
Fantastic. That's a great point. One of the questions that came up actually, you mentioned, Dr. Laverick, a couple of minutes ago about how you had a patient with a twisted pouch, and how that was sort of seen in a patient with a prior history of robotic deployment or the robotic pouch creation. How do you approach somebody coming in with a twisted pouch? My colleague, Dr. Hollybar, had to leave because I think he's actually creating a pouch in the OR right now. But Dr. Laverick, how do you approach the workup of somebody who's you believe or suspect is having a twisted pouch, and what are some clues in the history that make you think maybe this could be a twisted pouch configuration?
Yes, thank you. So first is to go back to the operating notes and to really follow kind of every step of the procedure, pay attention to the attention there and nuances, how the stapling of the rectum was performed, how they measured the lengths of the rectal cuff, how it describes the orientation of the cutoff edge of the mesentery, small bowel orientation, the test of the reach, and afterwards you have to sort of examine the patient. So normally we would take patients to the operating room for the examination under anesthesia, to both look at the anal canal and also to do an endoscopy under anesthesia to look at those staple lines. And normally you can see it on the endoscopy that they're sort of swirling. Would also perform an MRI and an MRE, and we really want to look at the mesentery of the pouch, if it's anterior or posterior, and see what the surgeon had described in their op note, how they orient the mesentery of the pouch, because majority of people put it posteriorly, but some surgeons do it anteriorly. And if that's what they said, but on the MRI, you see that the pouch mesentery is posterior, that's concerning. Dr. Holber here has now developed his pouchogram where he looks at the staple lines crossing. I mean, it's a fantastic tool to look at as well.
Thank you again, Dr. Laverick, and thank you again for all the panelists. I think I had a wonderful experience going over how we as a group manage the multidisciplinary complications associated with pouch and how we review these patients as they come into the practice. I do really want to thank all our panelists as well as our speakers today, Dr. Laverick, Dr. Braga-Neto, and Dr. Spivak. Once again, for our panelists, including Dr. Falloon, who came in late, but also Dr. Cantors and everybody else, thank you again for coming in. It really is helpful, and Dr. Qasim for the cases today. Thank you again to all the participants. As we hit the wrap-up slides, join us for our next live from Cleveland Clinic program series on February 12th, the non-surgical management of chronic pancreatitis with Dr. Matthew Walsh. Thank you again to everybody who came today to the talk and to our group, and thank you all the participants. It really had a wonderful time going over some of these cases. I really do have a soft spot in my heart for managing some of these patients, and I couldn't do it without my team. So thank you again, guys.